Good morning. Thank you for joining me today. My name is Jake Scott. I'm one of the pediatric anesthesiologists at Children's. Spend most of my time working in the heart room, both in the operating room and in the ICU. Today I'm going to be presenting anesthetic considerations for non-cardiac surgery in patients with congenital heart disease. I have no relevant financial or commercial disclosures to report. The objectives for today's presentation are to review the background of congenital heart disease, to review some perioperative anesthetic management strategies, and to discuss the model we employ at Children's Wisconsin. So the incidence of congenital heart disease is about 1%. It's the most common congenital birth defect. The coexistence of extracardiac malformations is common, and many of these require surgery. And in this setting, the perioperative risk is increased. This is an article from 2014 in Pediatric Cardiology examining the prevalence of associated extracardiac malformations in children with congenital heart disease. It was a multi-center case control study. There were nearly 100,000 patients with congenital heart disease and 12 million patients who were controls. And as you can see from the data presented, the rate of non-syndromic congenital anomalies, genetic syndromes, and extracardiac congenital anomalies was increased in the setting of congenital heart disease. This is a more recent study from Nature Research from 2020. This was a database study from the Pediatric Health Information Systems database, which includes 52 hospitals, of which about 38 of these hospitals reported. And the slide on the diagram on the bottom left shows the number of non-cardiac procedures per participating center. And what this study demonstrated was that there was a trend of increasing non-cardiac procedures in patients with congenital heart disease from approximately 38,000 in 2015 to over 46,000 in 2019, and that was highly statistically significant. Interestingly, they showed a trend of decreasing mortality over the same time period, but this was merely to show the prevalence of these procedures is increasing. This is an older study, and when we start talking about these procedures and risk, and this may not apply in the current era, but this was one of the first studies to look at risk in patients undergoing non-cardiac procedures with congenital heart disease. This was a single center study out of Michigan. It looked at congenital heart disease patients over a 10-year period. And what they found was that overall mortality was about 12%, and there was a difference between minor procedures and major procedures. And from this work, they were able to assess what they thought were some risk factors for death, and a lot of these are probably intuitive. ASA physical status greater than or equal to 4 was highly significant. If you were in the hospital for 10 days prior to a procedure, which would suggest a severity of illness preceding the procedure, greater than 10 days was also significant. And finally, emergency operations were noted to be a risk factor. This is a more recent study. This is the POCA registry. Sorry, I'm going to mute my Volt. This is the POCA registry, looking at anesthesia-related cardiac arrest in children with heart disease. And this is from ANA in 2010. They looked at 373 anesthesia-related cardiac arrests over a 11-year period. About a third of these were in patients with congenital heart disease. And in these patients with congenital heart disease, they found similar sort of risk factors: higher ASA physical status. The arrests, interestingly, in patients with cardiac disease were more often cardiac in nature as opposed to the rest of the cohort, who were more often either respiratory or non-determined. More than half of the arrests occur in the general operating room rather than in the cardiac OR or in the cath lab. About 3% occurred in the radiology suite. 3/4 of the patients were under 2 years of age, and most of the arrests either had a single ventral lesion or an unrepaired lesion. This is a little more information from that same study. The deaths tended to occur in patients who either had fixed obstructive lesion or cardiomyopathy, or single ventricle. So if you had aortic stenosis, severe aortic stenosis, you had about 62% risk of mortality. If you had cardiomyopathy, it was a 50% risk of mortality if you hadn't suffered an arrest. And like I just stated, that 3/4 of the deaths occurred in this high-risk cohort. This is a study from 2019 trying to develop a risk scoring system for patients who are at risk for perioperative mortality for non-cardiac procedures in the setting of congenital heart disease. So what this was a derivation and validation study using the American College of Surgeons NSQIP database. The first 2 years from 2012 to 2013 were used to derive a risk scoring system, and these were the variables that derivation process generated to identify risk stratification. And as you can see here, emergency procedure, severe congenital heart disease, which they listed as cardiomyopathy or profound ventricular dysfunction, single ventricle physiology, surgery within 30 days of the procedure, previous surgery, the need for vasoactive support prior to the procedure, preoperative CPR, acute kidney injury, and the need for mechanical ventilation were all highly significant and generated some weight for the risk scoring system based on that. This is a diagram from the same study, essentially comparing the observed mortality with the score that was generated. And I think what is telling here is that when they did odds ratios, that as the risk scoring system increased, the odds ratio of mortality increased. So if you were greater than 7, your odds ratio of mortality during the procedure was greater than 22. So how do we minimize morbidity and mortality in non-cardiac surgery in patients with congenital heart disease? So I think a lot of this is intuitive, and these are things that most of us do on a daily basis. There are critical elements to a safe delivery of anesthetic care to patients with congenital heart disease, and it really starts with when you're preparing for the case. So the preoperative assessment and risk stratification are essential. It's important to develop an individualized anesthetic plan, and then there are considerations for post-anesthetic care. So when we talk about a preoperative assessment for a patient with congenital heart disease, it's important to first and foremost think about what the lesion is and the circulatory physiology. Then you want to consider what the repair status is. You want to examine whether there are long-term complications of the congenital heart disease. It's important to think outside of just the cardiovascular system and recognize what other comorbidities are present that affect the ASA status. And then the type of surgery is also an important consideration. Ultimately, when you think about it, it's really all about the plumbing, and you want to know where the blue blood is going and where the red blood is going, and you want to have an understanding of what the pump is like. So there are many different ways of thinking about congenital heart lesions, and I'm going to present a couple here. But ultimately, no matter what the variant is, it's important really to try to understand where the blood exits the heart and how it comes back to the heart, and whether there are abnormal connections along the way. So this is the classic board question. Lesion type, you think about acyanotic or cyanotic lesions, and you have your 5 terrible T's when you're thinking about cyanotic lesions. So that's the transposition of great arteries, truncus arteriosus, total anomalous pulmonary venous return, tetralogy of flow, tricuspid atresia, and then you have this other category, which tend to be single ventricle variants of some sort, whether it's a hypoplastic left side or hypoplastic right side. But those tend to be your cyanotic lesions. These acyanotic lesions are all mixing lesions, and those are listed on the left. So there's your atrial or ventricular septal defects, your atrial, your AV canals, and then some degree of stenosis of the outflow tract, either aortic stenosis or pulmonic stenosis, and then coarctation of the aorta. This is another way to think about it, and I tend to think about it this way. This is really thinking about lesion type, and this is how I compartmentalize some of these lesions, thinking about whether the blood mixes before it leaves the heart, whether there's a single ventricle variant, whether there's an obstructive lesion, whether it's AS, PS, tetralogy, or coarctation, whether there's truncus arteriosus. And then these other two bottom categories are probably less well discussed, but probably equally high risk, which would be the cardiomyopathies or the systemic pulmonary hypertension cohorts. When we talk about circulatory physiology, it kind of at the basic nuts and bolts, it's important to think about whether the circulation is in series or in parallel, and that's comes down to basic physics. The series circulation, which you see here, is really what the normal circulation is. It's what we're thinking about when we deal with normal variants and many other forms of unrepaired congenital heart disease. And that's where your systemic circulation is in series with your pulmonary circulation. And the mixing lesions we just talked about, the ASDs, the VSDs, and the AV canals are all this sort of physiology. And then some of the more complex forms, as we'll see on the next slide, are parallel circulation. So in parallel circulation, the systemic and pulmonary circulations can communicate with themselves as parallel circuits rather than series. And this is common in single ventricles with a systemic to pulmonary artery shunt, so like a RVPA conduit or a BT shunt. The truncus arteriosus is another, and then unrepaired transposition of the greater arteries. So in parallel circulation, it's really important to think about what the balance of the flow distribution is. So the balance or imbalance of the pulmonary vascular resistance and the systemic vascular resistance determine whether blood flow is distributed evenly or maldistributed in settings where there's imbalance. So ideally, there's ratio of systemic to pulmonary blood flow is equal, and that's nirvana. If you have too much pulmonary blood flow, that's the QP greater than QS, that puts you at risk for systemic hypoperfusion. So what you're seeing there is that you have risk for mesenteric ischemia or NEC, frequently in small babies. Also, you can have increased pulmonary blood flow and generation of pulmonary edema and generation of interstitial pulmonary water. If your QP is less than QS, which happens in some other variants, you tend to be cyanotic, and that's why you see the blue line group. So single ventricle circulation, what does this all mean? So single ventricle is where you have hypoplasia of one of the outflow tracts of the heart, so either the right side or left side. It's not amenable to biventricular repair, and it requires staged palliative procedures to create a functional series circulation from essentially a parallel circuit. And that's what this slide shows here with the classic example, which is hypoplastic left heart syndrome, where you have failure to develop the left-sided structures of the heart, from the mitral valve to the left ventricle, to the aortic valve, to the aortic outflow tract, and beyond. All right, so in order to preserve systemic outflow in these patients, you have to generate a systemic to pulmonary artery shunt, and that's and as well as opening up the left-sided outflow tract, and that's what occurs in the Norwood procedure that you can see on the left there. So essentially, the right ventricle is made to be the systemic ventricle. You have an opening of the systemic outflow tract, and then you have a systemic to pulmonary artery shunt to perfuse the pulmonary blood flow in the setting of this reconstructed left ventricular outflow tract. And so that's a parallel circulation. At about 3 months of life, or 3 to 6 months of life, that physiology, which is your highest risk period of of death is then converted to more of a series circulation with mixing, in which the right ventricle still functions as your systemic ventricle, but the systemic to pulmonary artery shunt is taken down, and then this superior vena cava is connected to the pulmonary artery to create a form of passive pulmonary blood flow, while the lower extremity blood flow, the inferior vena cava blood flow, etc., comes back to the common atrium and mixes there as well. At about 3 to 4 years of life, this IVC connection is taken down to create the Fontan circulation and connected to the pulmonary artery. And this creates essentially a functional series circulation without a pulmonary ventricle. And so as you can see here, those three stage procedures create a functional series circulation from what was once a parallel circulation. So now we've discussed circulation. It's important to consider what the repair status is. So in its most basic form, you want to understand whether the lesion has been repaired or not. So if it's unrepaired, the considerations are different than whether it's completely repaired, and different whether it's completely repaired with residual lesions. And finally, the paleosigmoventricular lesions, which we just talked about, are important to understand where the patient is along that pathway. After thinking about what the repair status was and what the circulatory physiology is like, it's important to understand whether the patient has complications that they've acquired from long-standing congenital heart disease. And the complications we're going to talk about today are heart failure, pulmonary hypertension, and arrhythmias. So heart failure, I think we're all familiar with the signs and symptoms, but just to review, in children, heart failure is associated with tachypnea, tachycardia, sweating, cool peripheries. More commonly, what we see are more subtle findings in children, such as poor feeding, failure to thrive, and hepatomegaly. In all age categories, it's important to consider what the functional status is, and so this is a summary of the New York Heart Association functional status, and we include this in our preoperative evaluation for all patients undergoing surgery at Children's. So functional class status 1 essentially is somebody who has no symptoms, no limitation at all. And as you progress through stages 2 through 4, you get to a place where somebody has symptoms even at rest. So it's important to just broadly think about where each patient is along this continuum when you're developing an anesthetic plan for a patient with congenital heart disease or other acquired heart disease. This is a study from 2011 looking at patients who have more severe forms of heart failure undergoing non-cardiac surgery. And so in this study, they identified severe heart failure as a fractional shortening less than 15%. And it was a very small study. There were only about 22 patients in it. But what they found is that in the setting of a fractional shortening less than 15%, 2 out of the 20 patients suffered a cardiac arrest. And essentially every patient in the study required some form of vasoactive inotropic support during the procedure, which highlights what many of us practice on a daily basis in the setting of these more severe forms of heart failure, that it's essentially expected that you're going to need to support the pump function of the heart with the addition of sedative hypnotic medications, which frequently are potent negative inotropes. The next acquired complication that we want to talk about is pulmonary hypertension, and I think this is only here to highlight a few issues. The first is that the definition of pulmonary hypertension has evolved. It previously had been a mean pulmonary artery pressure of 25 at rest, and after 2019, it's been reduced to 20 millimeters of mercury at rest. The vascular resistance criteria have remained unchanged, which is 3 Woods units, and the PBRI is just adjusted for body surface area. What we know is that the severity of pulmonary hypertension does predict morbidity and mortality, and that concurrent upper or lower respiratory tract infections are really poorly tolerated in the setting of increased pulmonary pressures, because they significantly impact the pulmonary vascular resistance as well. So similar to the New York Heart Association functional status, there's a World Health Organization pulmonary hypertension score. And I only included this here because it's essentially the same. The importance here is that it really tells you what is going on with the right side of the heart. It's supposed to give you an idea of what the strain is or the failure is that's ongoing and on the right side of the heart. So if you're class 1, you have no limitations. But if you have a patient with pulmonary artery hypertension, which is likely systemic pulmonary artery pressures at the class 4 rate, they have a high degree of right ventricular strain or failure and are very high risk for perioperative complications. The next complication we want to discuss is arrhythmias. And these are very common in patients with congenital heart disease, both after their cardiac procedures and non-cardiac procedures. The most common variants tend to be supraventricular arrhythmias, and these are generally benign. But the important takeaway is that ventricular arrhythmias or ventricular ectopy is not normal. There are risk factors for the development of ventricular ectopy, and these include previous ventriculotomy. So if you have a patient who needs an RV to PA conduit, patient who has a transannular patch for tetralogy of flow, when there's a previous ventriculotomy, that increases the arrhythmogenic risk. And also patients who have coronary insufficiency for one reason or another. And when you have ventricular ectopy, it's a risk factor both for sudden cardiac death in the operative setting and in the non-operative setting. This is an article from Pediatric Anesthesia in 2011 from White and colleagues. And this is really a summary table looking at what specific lesions are associated with with specific arrhythmias. And as you can see, some of the classical procedures, the atrial switch, the muscular sending procedures, have an increased risk of sinus node dysfunction and both ventricular and dysfunction and ventricular arrhythmias. Lesions with large atria or atrial dilatation can be you could expect atrial tachycardias. Single ventricle circulation is really at risk for significant ventricular dysrhythmias that can lead to sudden death. And finally, the tetralogy of flow, which we just talked about, because there's a ventriculotomy that may result in injury to a coronal branch of the coronary arteries. There's a risk for sustained ventricular tachycardia, both due to the injury to the ventricle itself, but also because in the setting of poorly decompressed right ventricle, the right ventricular hypertension can also increase arrhythmogenic risk. Finally, we want to talk about surgery type when we get to the preoperative assessment. So there are major surgeries that increase perioperative risk in congenital heart disease, and these are a brief summary. So major intraperitoneal or intrathoracic procedures, large vascular reconstructive surgeries, and any procedure where you expect major blood loss and fluid shifts. So with that, we're able to generate a comprehensive perioperative risk assessment that allows for risk stratification. So the low-risk patient, based on what we just talked about, is a patient who's physiologically well compensated, has repaired congenital heart disease, is having a minor elective procedure, tends to be greater than 2 years of age, and has ASA physical status 1 to 3. Intermediate risk is the patient who is physiologically very well compensated, no evidence of end organ dysfunction, tends to have true ventricular heart disease, may be undergoing a major procedure, a spinal fusion or a major intra-abdominal procedure, where blood loss is likely, may have less than 2 years of age, emergency surgery and ASA 3 status. And finally, the high-risk patient who's at high risk for perioperative morbidity and mortality is the patient who presents with poorly compensated or decompensated physiologic status, may have heart failure, may have systemic pulmonary artery pressures, has complex lesions, so either a single ventricle cardiomyopathy or a fixed obstructive lesion like aortic stenosis, has preoperative risk factors that suggest morbidity, such as the need to be mechanically ventilated prior to surgery, the need for preoperative vasoactive or inotropic support, has end organ dysfunction such as acute kidney injury, is undergoing a major surgery, is young, has emergency surgery, and is ASA 4 or 5 status. So how do we manage this at Children's? So we develop an individualized anesthetic plan. The areas addressed are the anesthetic technique, whether it's a volatile-based technique or a IV sedative, opioid analgesic technique supplemented with a volatile anesthetic, what sorts of monitoring, advanced monitoring we want to employ, what the special considerations are for SBE prophylaxis, vascular access, what we want to do with their home medications such as ACE inhibitors or anticoagulants, and what the expected disposition would be. So just to review the updated SBE prophylaxis guidelines for congenital heart disease, it's no longer recommended for congenital heart disease other than in these 3 settings. So unrepaired cyanotic heart disease, including patients with shunts or conduits, repaired congenital heart disease with prosthetic material 6 months post-op, and repaired congenital heart disease with residual defects. So that's abnormal flow next to a prosthetic patch or device, and that's lifelong. So back to our model at Children's. So we have a cardiac anesthesia team, and decisions regarding the need for cardiac anesthesia are based on risk stratification. Cardiac anesthesiologists are available as consultants for any procedure in patients with congenital heart disease. We have an EPIC-based pre-anesthetic assessment, just like EPRADER in the VA. What is unique is that we have an organ-specific scoring system, which allows us to differentiate between cardiovascular and non-cardiovascular risk factors. And through that, we can generate a comprehensive ASA physical status. And that allows us to assess cardiac and non-cardiac risk. So for a complex procedure anesthetic plan, we'll send out a plan to the team caring for the patient. It includes the medications that we're needing, whether those are drips, vasoactive support drips, whether those are sedative hypnotic drips, lines, blood products. The sequence of events in the operating room are clarified. The surgical and the operating room teams know what to expect, and then we have the expected disposition and postoperative management plan included as well. So a low-risk plan based on the criteria we showed on the previous slides would be a midazolam pre-medication. We generally do an inhalation vapor-based induction. The anesthetic would be vapor-based with adjuvant therapies, including perhaps regional anesthesia, neuraxial anesthesia, opioids, dexmedetomidine, and we'd have a planned extubation in the operating room. A high-risk plan tends to be opioid and IV hypnotic based, so benzodiazepines and dexmedetomidine are commonly employed in this setting. It would be vapor supplemented. We would incur a higher level of monitoring. We would expect to have vasoactive supports available both vasoactive and inotropic drug availability. And then the need for consideration for likely postoperative mechanical ventilation based on what the procedure was and the recovery. In terms of advanced monitoring, we are an institution that deploys NIRS monitoring for most, if not all, intermediate and high-risk cases. In terms of the organ-specific scoring system, which we just referred to in the last page, a threshold for most of us caring for these patients would be a cardiac organ-specific score greater than 3, which suggests significant impairment. And then blood pressure monitoring and CVP monitoring is generally reserved for high-risk cases, but there are certainly intermediate risk cases where these are required as well. So this is a slide just briefly to talk about why we use NIRS monitoring as ubiquitously as we do. This is a study published by Dr. Hoffman looking at two-site NIRS monitoring as a predictor of SpO2, which is a surrogate for oxygen delivery, which is a surrogate for cardiac output. So it tends to be a reliable trend monitor, particularly in small children, less than 10 kilos, but in most children, we find it to be highly reliable as a trend monitor for what venous oxygen saturation is within the regional bed that you're monitoring, whether it's the cerebral venous bed or the renal somatic or mesenteric bed that we deploy these monitors on. And it allows us to identify when oxygen delivery is compromised, which suggests that we have a reduction in cardiac output. In terms of disposition, for intermediate and high-risk patients, we generally have a low threshold for sending these patients to a high level of postoperative care, which tends to be our cardiac intensive care unit. And that is due both to the need for higher level monitoring, which may not be available in other settings, particularly some of the non-invasive monitoring, which we just discussed in terms of NIRS monitoring, but also nursing competencies and provider competencies. So in summary, physiologic well-compensated congenital heart disease it is well tolerated, and patients can undergo elective operations at low risk. However, patients with poorly compensated disease requiring either urgent or major operations are at increased risk. An anesthesiologist must understand the anatomy, the physiologic status, and the operative implications for the scheduled procedure to reduce perioperative morbidity and mortality. And that is all I have, and hopefully I've left enough time for Dr. Lean to present her topic for today. Happy to answer any questions.
Thank you, Dr. Scott, for the presentation. There's plenty of time for questions. I really only need a few minutes. So if there are any questions, please unmute and ask them or share them in the chat box.
Hi, Jake and the audience. This is George Hoffman. That was very comprehensive. I think if you didn't understand everything, that is sort of the point. The field is very complex, and I'm still learning this after a long time. So to apply to really understand the circulatory anatomy, given the innumerable variants and complexities of repair, I think is a real challenge. And as Jake said, if you don't understand the anatomy, it's very hard to manage the physiology. So I would just emphasize that the complexity is enormous, and we emphasize a team approach to these things because of that complexity. So I don't want to talk anymore. I'm trying to fill in for other questions. This is I would be interested maybe in responses from our adult colleagues about the range of anatomic congenital anomalies that the adult cardiac service deals with. We have some, we basically leave it up to the cardiologists to determine where patients go. And I think there's room for more collaboration there.
Hi, this is Chris Plombeck. So I probably see the majority of these patients on the adult side, and probably the common lesion we're seeing that involves sort of specialized care. The Fontan patient, we're seeing lots of them on a frequent basis. The tetralogy of flow patients are quite common. So outside those two groups, it's sort of just a random assortment of the lesions, but probably the Fontans are probably the most intense patients that we take care of on the adult side from the adult congenital heart disease standpoint. But we have a really great group of cardiologists that we work with, so they're very helpful in managing these patients.
Chris, what is the model you employ for caring for those patients? Do cardiac anesthesiologists, adult cardiac anesthesiologists care for those patients, or is it done in collaboration with non-cardiac anesthesiologists?
So just at Freighter, most of these patients, when they're identified in the excuse me, the pre-op clinic, will go through me. I'll review them individually, case by case, and then I sort of do a triage assessment based on the severity of the lesion. So either they're managed just by the generalist anesthesiology if they're low risk, or if they're higher risk by the cardiac anesthesiologist. And frequently some of the most severe risk ones I'll take care of myself, just because from the group I've probably had the most experience taking care of them.
Thanks.
Jake, just quickly, this is Kathy Lauer. One
Hi,
of the
Kathy.
things that we have, hi, good morning. Great talk this morning, Jake.
Thank you.
One of the things that we have implemented is that we have a triage tool that is used by all the surgical clinics, so that when a patient is seen who has known congenital cardiac disease, those patients are routed through the anesthesia side of pre-admission testing. So as many of you probably are aware, we have a shared space with internal medicine, and we co-direct the clinic with the Department of Internal Medicine. And in that way, we are able to make sure that they all come through us so that we can help facilitate care management, contact our colleagues, make sure that it gets coordinated. Oftentimes we'll, go through our scheduling coordinators just to make sure that we have all of this stuff put together. And it generally works really well. One of the questions that I have is that we have started implementing the Duke Activity Scoring Index on every patient, really in the last probably 6 months. Chrissy Boxhorn's on, and she could also speak to this, but on the adult side, we are DASI scoring really every patient that comes through. And right now we're getting ready to launch Enhanced Recovery After Surgery, and this will be embedded in all of our tools. So what I'm wondering is, have we looked at anything related to activity scoring? I know children are a different animal than adults, but many of the questions that we ask may give us some insight into how they're doing and how to classify these patients.
I'm not aware of a systematic approach on our end, but by and large, all of us who care for these patients will do a thorough assessment of functional status as we're trying to determine perioperative risk, and that's part of the reason that both of those functional scoring systems were included in today's talk, because I think that you identified an issue that it is sometimes more challenging to to really characterize functional status in small children. But certainly it is easier to identify a deterioration in functional status. I think most parents are able to describe a reduction in activity or activity tolerance, and being able to keep up with friends, symptoms at rest, those sorts of things. And when we encounter a patient who presents with those symptoms, it is definitely a red flag. It's a great question, though, and I think that's something we certainly could and should explore. We are also spending a significant effort in looking at enhanced recovery after surgery pathways for our cardiac procedures in this population, but really have not, because of the heterogeneity of congenital heart lesions. I think it would be somewhat challenging to deploy this sort of process in, say, for example, spine surgeries or things like that, because really there is so much diversity that the recovery pathways are truly divergent. But thank you. Thanks for the question.
Thank you.
Jake, this is Cindy. I just wondered if you could share a bit more detail. You had mentioned assignment of ASA classification and intimated that it was based on a systemic analysis, and almost, I wondered what the algorithm was or the science was behind it, or is it strictly based on ASA definition of the classifications?
It's based on the ASA definition, and this is the slide I was talking about. Dick Behrens and George spent considerable effort as we were building our EPIC platform in 2012 to develop what was an organ-specific scoring system, looking at each of the the 5 major organ systems, with other being a kind of a miscellaneous category, and trying to assess what the overall limitations were for each one of these systems. So, for example, a patient who is morbidly obese would be an other of at least 3. A patient who has profound cardiovascular limitation could be anywhere along this 3 through 5 spectrum, depending on how severe their cardiovascular limitations are. A patient who has profound neurologic deficits would likewise be considered at least a 3. And then when you add up all of these factors, you want to, what we've determined as a group, and this is actually an example. So the cardiovascular status, so this could be a patient with hypoplastic left heart syndrome who could die with a systemic to pulmonary artery shunt, who could die at any point due to shunt thrombosis. So they're categorized as a cardiovascular status 4. And the highest scoring system essentially should default to what the ASA status of the patient is. So it allows a organ-based assessment of limitation, which then is compiled into a comprehensive ASA status. And so Dick and George deserve all the credit for this. It's something that I think is relatively unique to what we do, and certainly aids in our assessment preoperative patient risk.